Hello, everyone. I'm Rose Gerber, the Director of Patient Advocacy and Education for the Community Oncology Alliance. Surprise, surprise. Today, we're not going to be talking about PBMs or any of the policy issues that COA loves to talk about, but we're talking about something equally important. It is an issue very important to COA, and this is health equity. And as you can see from the photo on the slide, as well as our speaker on the side, maybe you can see him. We are very honored today to have Dr. Martin from Tennessee Oncology, who is the Director of Health Equity and Community Engagement at Tennessee Oncology. And if he looks familiar, he's done a lot of national speaking, so he's an expert on this subject. And also, I noticed that this wasn't in the slides, but he's done incredible publications on the topic as well, so jot that down. Dr. Martin, thank you so much for being with us today, and the floor is yours.
Well, thank you, Rose, and thank you to COA, CPAN for this opportunity. Obviously, I'm always accepting of opportunities to spread the gospel of health equity. So let's take it away. I will try to get through essentially a 30-minute talk in about 25 minutes. So if folks want to post questions in the chat, I will get to those first if people have to jump off. But I'm also going to stick around after for anybody who wants to stick around and has questions about any of these topics. So starting out with how to be an impactful clinical equity champion. Next slide. So I want to start with patient scenarios because ultimately that informs kind of everything that I do as a clinician, and talk about some real world experiences that I've had where the rubber really hits the road around health equity. While I didn't take care of Chadwick Boseman, his example was somebody that I did take care of, 43-year-old who had a family history of colon cancer and then presented with metastatic colon cancer and is devastated and kind of wants to know how this could have happened to him. Next slide. So forgive, the outdated slide here, but it's kind of the point that even up to 25, 30 years ago, we've known that among Black individuals that they seem to present with colon cancers at an earlier age. And yet during that entire time, there really haven't been any racially focused screening differences. And one of the points is that differences between people of races, ethnicities, that's okay. That's actually something that we should embrace to think about different screenings, different therapies, be patient-centered and population-centered. Where that can be a problem is if that's stigmatizing or comparing groups in terms of inferiority or superiority. But really, if we're trying through a good faith effort to provide the best care to the best patient at the best time, differences do exist. Some of those are racial. Sometimes race can actually be a proxy for access or dietary environments, things of that nature. But at least using that as a signal to say, here's a community in need. How do we begin to ask the scientific questions that can help us support that community in a clinical way? Next slide. So we have now recently extended colon cancer screening to an earlier age cohort, as we're beginning to see a similar trend across all racial groups, but there's still no kind of racially focused screening recommendations. And just, again, watch this space. This is something that I think we need to continue to think about and take it where the data leads us if what we're trying to create with that is something to improve health equity, as opposed to just label one group as different or worse or better than another. Next slide. Another example, had a privilege of taking care of a really sweet 63-year-old lady who was a smoker and had non-small cell lung cancer, which is a type of lung cancer that typically can have more targets, more targetable therapy. She had something called PD-L1, which is an imperfect, but it is a predictor of whether new immune therapies might be successful in treating that person with or without chemotherapy. And she's really interested in knowing with her score if immunotherapy is something that could work for her. And the question is, if I'm as a provider going to have a truly informed consent process, what does that look like for this patient, and what can I tell her? So next slide. And unfortunately, not much. Immune therapies first came to light being used through a model cancer of melanoma, which is much more common among white individuals. But as it was really a game changer in that cancer, it's moved into several other, almost virtually every solid tumor at this day and age. And yet the trials that have operationalized and informed the use in those other cancers, if you move forward with the animation, just highlight that even in those other cancer types, which are much more common among Black, Asian, Latino population, that they really were not included in the trials. And in some of our ASCO and other plenary discussions to say this is a new standard of practice, you're talking about maybe 12 people within the Black community who had an option to be on that medication in that trial. That is significantly underpowered to inform any real world application, or to be able to tell that person sitting in front of you whether that medication is truly going to work for them. We obviously don't want to withhold therapies that we think in other groups are a game changer, but we need to do a much better job in inclusivity and research so that we can have a truly informed consent conversation. Next slide. One other example, a 39-year-old transgender Latina who I had the privilege of taking care of, and a couple different teaching points here. So I reflect on the fact that particularly around in this country right now, around folks who may identify as transgender, that seems to be a sticking point where, because it's an identity that's harder for many Americans and many people to grapple with and how to speak to or respond to that person, that it tends to be the only lens in which we embrace their identity or don't embrace their identity. Whereas someone like myself, who may be white, a dad, a doctor, a really big European soccer fan, I can wear all of those identities simultaneously, and people can flip in and out of those and understand that I'm all of those things. And so just an awareness that when identities may be a little more nuanced or harder for folks to understand, not to put blinders on that in a different space, this person's Latina identity or experience, or maybe that she's a nurse practitioner, might be the identity that comes up. And so just to be aware of that and how we talk to people and how we try to either enroll them in trials or engage them in conversations, to be respectful of those multiple identities. Next slide. The other issue is in folks who are transitioning and maybe taking things like hormone replacement therapy, is whether that could put them at risk for things like breast cancer, ovarian cancer. There is a model in cisgendered women that long durations of hormone therapy can increase your risk of breast cancer. Right now, the data says that in this group, not yet. However, many of these individuals are younger than the age at which people typically develop breast cancer and have not been on hormone replacement really long enough, beyond 5 or 10 years, to where we would detect that signal even in a cisgender population. So I think we need to continue to watch the space, but also, this is a classic example of designing trials and asking questions that are really powerful and important for certain communities. The other piece is, as we're developing more novel therapies, we're often using genes or molecular testing to help identify reasons for cancers that we now have drugs that can shut those things down or target them. But there are many, many different ways that those genes can be mutated or have problems. And sometimes those actual problems, or those mutations, occur in different patterns depending on where in the world your ancestry is from. And so while we might know that a certain mutation is a problem when we have a large group of people, white people in the United States, when we have smaller communities where we don't know if that same mutation is a problem or not, or is even actionable, those are the types of questions that we really need to begin to answer so that we can make sure that people are getting the right therapies. Next slide. And that sets up this slide, which is when I, as a provider, this day and age, are trying to make sure I'm getting the right drug to the right cancer at the right time, I'm really looking at those cancer facts about where did the cancer come from, what stage is it, what are the genetic or molecular results, what other therapies have they had. I have to document all of those things. Insurance has to look at those to make sure, am I really choosing the right evidence-based medicine? But layering on top of that, I don't think we've yet cracked the code on personalizing it to the individual. And if you go to the next slide, I think that really the future of healthcare to maximize the best overall cancer care plan for the greatest number of people that is patient-centered, that is evidence-based, really does require looking not just at the cancer facts, but at the human facts. And I think if we develop data systems and opportunities to engage people as individuals and as human beings in shared decision-making that can combine both of those things, that's really what equity is all about. So that's what I'm going to be talking with you about the rest of this talk today. Next slide. I don't have any other disclosures to report. And so really it's about, as a champion for equity, why now? What are kind of the incentives that we can talk about across stakeholders? Who are those stakeholders? And then kind of show you a plan to action that we've been doing locally at my community oncology practice. Next slide. So no conflicts to report. So I think, this is a great place. I love this job. I love my job to be able to do these things. I sleep well at night. I feel like I'm at least trying to make a difference in the world. But at the same time, I don't think that everybody has to have that same value or duty in order to do this. I think there are some real return on investment, some real kind of brass tacks arguments to why this is helpful. And that's, again, around can you truly consent a patient if they were never included? Is it going to improve outcomes? And if we're going to be held accountable for things around value-based care and other healthcare outcomes, are reaching more patients with the right treatment, the right diagnosis in a patient-centered way, does that improve the patient experience and result in better outcomes? So I think better systems, as the Institute of Medicine taught us around their quality report in the early 2000s, equity was actually one of their 6 principles on high quality care. So better systems overall are inherently more equitable. So next slide. And what do I mean by that? I joke that I probably would not have gone into oncology in the 70s or 80s. So for those of you who are nearing retirement or were kind of the giants on the shoulders in which we sit, kudos to you for putting in the groundwork that really now has truly paid dividends. Because fact of the matter is, whether you got some novel therapy or the old stuff, probably not a lot of difference back in the day. But now, if we move the animation further, these new drugs are much better. They're not where we want to be. We're not curing as many cancers as we could or should, but they are a significant improvement. And if you go to the next slide, and then progress the animation, when things get better, the flip side of that is that's actually an opportunity to perpetuate or increase disparities, because now when you have better technologies and treatments, there is this second order issue of who's getting those and who's not. And if these things now exist and there's a broader group of people who are not getting these, they're really even further falling behind. And I think that's where we're victims of our own success. As we're creating these better treatments, now there really is an obligation and a duty to make sure that everyone has access to these life-saving medicines. Next slide. And it's not just in our cancer medicines. We're now showing that if you can round that out with supportive care, with good palliative care, that people through cancer treatments are not getting infections, they're not getting dehydrated, they're not ending up in the ICU or the hospital, then not only is that a better quality of life, but it actually improves their survival. And so focusing really on good comprehensive supportive care services makes a difference as well. And what do those supportive care services look like when people may have different languages that they speak, different ability to communicate their needs or their symptoms? We're trying to identify things through systems called ePros, or electronic patient-reported outcomes, but are we developing those tools in a way that can connect with people with different health literacy, internet connectivity among our rural populations, and really multifaceted languages, or even the culture around how people report different symptoms, where depression and pain may be confused depending on how people are used to articulating those types of needs. Next slide. And then even thinking more about food, housing, utilities. The great study looked at really in people who are impoverished and have food insecurity, that they're really having to make some hard decisions around whether they pay for their food or their medications, and that impacts their medication use. And my God, if those things are potentially life-saving or life-extending cancer therapy pills, that's a big problem. So something that we need to say, where's our accountability if we're really focused on keeping people on treatment, giving them good outcomes? Is something like food really also within our purview of something we should be expected to offer or support as a healthcare system? Next line. So I see it like this. There are these things called social determinants of health, which is really the overall environment, a social constructed environment, mind you, where people are born, grow, work, live, that's going to influence their opportunities for employment, for financial security, for health security. And that's really just kind of the underlying environment. Within that, there can be services that are not health core services, but other things like food, housing, transportation, utilities that directly impact their ability to seek out and receive healthcare in a consistent and evidence-based way. And so starting with our core services, no matter what you do, whether you're on this call as a patient advocate, primary care provider, oncologist, is I always think about what is my core service? What am I the expert in? What's at the top of my license? But is that being impaired? Is that being impeded within certain communities or within certain systems because the other things kind of in one zone of proximity around me are not as good as they could be? And what is my role? Where is the accountability for me to help improve that landscape around me so that I can actually do a better job with my core service? And that's another, I think, for me is a compelling argument and a way to look at this. Trying to help me do a better job for what I do best. And it's all connected. So next slide. So now getting kind of that landscape to get buy-in from different stakeholders, payers, corporate stakeholders, my practice. Next slide. And we're at a really great time where I think because we're recognizing again that this is becoming a difference of the haves and have-nots, and that we really don't know whether these drugs work in every community because they were not included in research, and yet they cost a lot of money. And payers are going to say, God, if you haven't proven that it works in that community, we don't really see a compelling reason to pay for it. There's a lot of pressure, both at the FDA level, in order to give labels to medicines to make sure they work in everybody, to improve diversity and also US enrollment, and then also looking at different types of payment systems like value-based care, where we may be, as practices, in two-sided risk, where if we can provide really high quality, evidence-based, low-cost care that's patient-centered, we'll get rewarded for that, for saving and providing better outcomes. However, if we aren't really good at that, we may actually be penalized. And embedded within some of those models, which we'll see in a moment, are some things around health-related social needs and health equity. Next slide. This is exactly as I was referring to. Medicare, their next iteration of this alternative payment model, which is a value-based care model called Enhancing Oncology, does have some health-related social needs where we need to screen for, identify, and make a good faith effort to connect patients with transportation, food, or housing instability with those services. Right now, a lot of it is just holding us accountable to collect that and make that good faith effort, but every single time that this model has been improved, it's only furthered the goalpost to make it even harder. And I think that that's where the direction is headed, and I think it should. Next slide. And again, just thinking in terms of all of the new cancer therapies that are now existing year after year after year. And if we don't know what patients they truly work for, we're falling behind. And what's interesting is, the development of those medicines, while the pace is going faster, we go to the next slide, can take up to 17 years from the basic research steps to identify, and AI may really dramatically cut down on this time frame, but there's a lag between us thinking preclinical before we tested in cancer cells in mice, then phase 1, 2, and 3 in patients to finally get a label and say, this is going to be a game changer that needs to be a new standard of care. It takes a long time. And my point here is, again, if we reflect back on that 63-year-old lady with lung cancer that wasn't a part of those trials, yes, I can start putting her on trials for the future, but that's really going to help her get caught up about 10, 17 years from now. And we really need to reflect back on what are the current tools that exist today And how do we make sure we're getting caught back up, you know, with a 17-year lag from communities who weren't at the table for the things that are already existing? So more real world data, more real world publications on real world use and outcomes for those populations, I think is very important. And I would propose that for any future trial within a company, they may need to, in terms of equity, partner that with some real world publication, working with a community oncology program, an academic center, to at least put out a publication on real world use in a community that was on one of their previous therapies that never enrolled. Next slide. How do we do that? And how do we think about people in a way of doing that? I joke that, you know, no one's going to know what this is under a microscope. It's a very rare cancer called alveolar soft part sarcoma. And I bring that up because I was trained at Vanderbilt University, where they have one of the nation's leading sarcoma centers of excellence. And sarcomas are very rare cancers, and there are quite a few, and they even have rarities within rarities within rarities, where you might only see one of these every 3 or 4 years. And yet I can tell you that when we're thinking about rarity from a cancer standpoint, the passion of our researchers and how badly they would feel about missing an opportunity to enroll that cancer on a trial that might inform a better disease, I see that all the time. People are just so sad that they missed an opportunity to put a rare cancer on a trial, and I want to see if we can apply that same passion to rare people. Because on the flip side of that, I also hear, again, oh, I may only have a transgender Latina patient every 4 years. That's just a drop in the bucket. That you know, one patient on that trial, how is that going to help inform anything? But if we're applying that same rigor and passion to rare cancers, where it's hard work, and we're not applying that to people, I think it's a real missed opportunity. Next slide. And I say that because we do collect information about type of cancer, lines of therapy, genetics, and we can even attach that to trial matching services so that that individual provider doesn't accidentally forget an opportunity to enroll a rare cancer. Could we develop something similar where rare individuals who are interested in participating in research have a matching system that can alert the provider, alert the healthcare team, hey, here's a real opportunity to get somebody who is not historically represented in trials to be a participant, and they want to be a participant. So I think that's the next wave of the future as well. Next slide. Kind of skip over, I think, this what is equity slide. It's got several animations. I've given it before, except that what I really want to have the takeaway point is this is the disparities of seeing a couple people who get the outcome, some people who don't. That's kind of where the nature of our research has been in the last 30 years. What's a lot harder is to figure out the why, which is down below, and realizing that certain people require different levels of support. Sometimes it's not more or less, and I think we have to be really careful not to think about equity in terms of we're taking away from some and we're giving more to others. What it really is about, if we go forward just a couple more animations, because yes, I think we're concerned. This is time, money, this is people support, it's finite resources. Are we taking away and giving more to other people? And I think what it really is, it starts out with understanding people. So that's the next slide here. Understanding your people, and just understanding, again, on an individual by individual level, what do they need in order to have the best outcome possible? Sometimes we have found in healthcare system that less actually provides better outcomes, that if you go down rabbit holes of invasive procedures, invasive testing, not only are you spending more money, but you can actually increase risk of bleeding, infection, and morbidity, sometimes disability. So sometimes less can be more. And just to be, cautionary tale, that it really should just be not about comparing yourself to the person next to you, but if we operate as a healthcare system to think about what does this person sitting in front of me need, that should be the guiding force of equity. And it starts with getting to know your people. So next slide. And in getting to know the people, when I've been doing this work, one of the greatest areas for improvement that we can have is including people in those conversations. So when I have these conversations about, we want to go into this community, we want to help them, here's kind of who's always sitting at the table with me. If we advance, we'll see the people who I think should be involved. Patients, community organizations. Next slide. Here's a bunch in the Middle Tennessee, Nashville area, and I make a rule for myself that for every meeting I'm having with an industry or a pharmaceutical company or representative, some type of tech company, that I should be matching that one-to-one with a meeting within one of our community-based organizations, one of our non-governmental organizations that are actually helping out these groups, not necessarily with healthcare, but they understand the community, they understand their needs, they understand their barriers, so that if they do need healthcare services, we can really provide that in a way that's going to be more effective. Next slide. Ideally, it would be involving the community or some community representatives in a longitudinal process where at first you're just informing them, but eventually they begin to help give you some feedback into best practices. And then eventually they can even set the agenda and priorities and say, you know, this is the way that you should develop this program. And that's a process called community advisory boards, and it's something our company is looking forward to developing. There's been some models in academic centers. A lot of these are through research. The CBPR there is community-based participatory research through research grants. And we're really trying to develop and crack the code on how to leverage a private model that can be sustained and longitudinal in different communities. So watch this space for the next talk. Next slide. And this is just to say that if we're really thinking about equity, again, as the Institute of Medicine says, it's one of the hallmarks of high quality medical care, that it can't just be about meeting quotas, about meeting enrollment benchmarks, about really putting the blinders on and saying, how do I achieve equity in this one thing because I'm chasing some type of payment model. It really needs to be layered throughout everything you do. If you're going to enroll people in research to get them on the next medicines, only to have those medicines unaffordable or unaccessible once they hit standard of care, have we really thought of it in a comprehensive way? So I think of it both internally, what does our workforce look like? Externally, what does our community look like? And then thinking about it across all the services we do, whether those are standard of care, whether they are research, or whether they are those social services that help people obtain their medical care in the first place. Next slide. And can kind of skip this one, but I do think, I've been given a great opportunity here to think through these things. Wednesdays here, I have an entire day to sit and do things like this and just champion the efforts of equity for my company. It's a real blessing. I love that opportunity. I don't take that privilege lightly. But I think we are still really in the infancy in how we build out a team within a company. If it is obtaining the level of mission, what does that look like in terms of all the other infrastructure and capacity that we need within a company to execute? But we're making good progress, and I'm really proud of the progress that we have made as a company and really through COA as well. Next slide. So lastly, some plan to action in the last couple of minutes here. And just want to show you how we've kind of implemented some of these. So we have advanced practice providers. Those are nurse practitioners and physician assistants. We have so many in our company that are looking for opportunities for leadership, career growth, a chance to really make a difference. And our state society had a conference where we had some of our advanced practice providers talk about their advocacy efforts, about the things that they were doing through health fairs and community engagement. And it was the highlight of our entire conference. And not surprisingly, trainees, medical students, residents, even pharmacy, nursing students, they said, wow, I would love to get involved in that. I don't have a license, I can't prescribe medicines, but it sounds like this is some really cool stuff. So we're developing out this program, really aligned around education efforts, service efforts, and advocacy efforts, and getting volunteers from our community, patients, staff, trainees. And this is just one thing to really make sure that we're not just doing this, to use some jargon, willy-nilly, but we're doing it through a strategic way that can build upon itself and have consistency. Next slide. Couple other things that we're doing. This actually came as my brainchild after leaving the COA Payer Exchange Summit last year and giving a talk. We were all grumbling about what a terrible world it is that now that we can't prescribe medicines and ship them directly to patients' homes after the pandemic, and we're working on that. But I was really impressed that we could still get drugs in a rural Middle Tennessee network to all of these different clinics. And I just thought, well, gosh, what if we did that same thing with food? shelf-stable food. It's clearly less expensive than some of these really expensive medications. Could we just do what we're already doing with something slightly different? And I think that's a really great way to get buy-in and to help kind of move the needle, is thinking in terms of equity and social determinants of health as not these like really remote concepts, but if you think about it right, is how do we make it look and feel on a daily practice basis, almost identical to what you're already doing, but just change one small thing. And in this case, we were able to change a drug with a food box. Next slide.
I just got to jump in. That is so incredible. I'm very privileged to get to see the speaker's slides before, and it's so incredible what you've done. It's fantastic for patients and their families.
Yeah, I'm happy to do it. Thank you for that. But I mean, honestly, the real reward is seeing our patients get these food boxes,
Right.
and know that actually this is going to be sustainable. This is going to work. And
Right.
again, and also that our company culture, I'm here, whether you're a competitor, whoever's on this call, like we're happy to share these best practices, because around equity, this really should be a collaborative space. And that's kind of the mindset that our company takes. So yeah, thank you for that. And really happy to
Such an
share these
immediate
things. And
need
again,
being met.
connect with anybody after this talk as well. So we're almost wrapped up. I think there's maybe just one more thing that we're kind of doing something in terms of telehealth, as a way to get those supportive care services, which I said are also really important for outcomes and disparities. How do we get those types of services out to our more rural patients, through some hybrid models? And we're embedding our first ever rural community advisory board, so that as we launch this new technology and this new program, the rural community patients that we're serving can actually inform it and empower the program to think preemptively about their barriers and how to make it work for them. So that part we're really excited about. And I think that's about it. Just have one kind of last slide. Some other upcoming projects. I mean, we're just constantly kind of moving and moving and moving now. One thing I will say is, as you build capacity, the first step is always the hardest. And once you keep moving forward, you really do get some momentum. So don't be afraid to take that first step, which is on my final slide here. Takeaways, again, better systems are more equitable, among all the other things that they can do. So if you're making a case for equity, reflect on, am I needing equity to chase equity for equity's sake? Or am I trying to develop a better system? And then that is also going to be more equitable. It's got to be foundational across cancer services. Let's make it easy. Start with what you're already doing. Think about that zone of proximity, and think, if I actually do these things, can it make my core service easier to do? It always begins with the first step. Stay humble, listen. You are not the expert. I'm partnering with all kinds of different organizations that are like, where have you guys been? And suddenly I think, because, payers are at the table and other people are at the table, we're suddenly like, yeah, we care about this, and that's great. But there are lots of other organizations that are like, hold on, you guys, like, we've been doing this, and use them. They want to be helpful. As you build that capacity, it gets easier. I would say no matter what you're willing to commit to do in your next, Q1, yearly, 2-3 year, set some milestones and actually put it in your strategy, reflect back on it, hold yourself accountable. Certainly before any other group is going to start holding you accountable from like two-sided risk models, accountability's got to start somewhere. So set some aggressive goals, and it's very specific, those SMART targets, and hold yourself accountable and keep showing up. It's actually a lot easier than you think it is if you're consistent about it. So I know I'm a little over, darn it.
This is Dr. Martin. Thank you so much. This is fantastic. And as Dr. Martin mentioned in his opening comments, he's open to any questions. He has some extra time, which physicians very rarely have, right? You're taking care of patients all day. So here's your opportunity if you want to reach out. And while we're waiting to see if anyone wants to ask questions, your entire presentation was fantastic. I learned a lot. A couple of my favorite slides that I think are very helpful just for the audience is, I really like the slide that you had on the stakeholders, like who was at the table and who wasn't, and the thought process that the patient should also be there. And I think that is so important, because as patients, there's a saying that nothing about me without me, and you really can be humble. And if all those people around the table would bring in those other voices, you're going to do even greater work. So I was really glad to see that. And I think your Rural Community Advisory Board is doing that as well. So I think that's remarkable that you're walking the talk. And I know when we were exchanging emails, I said that's what's remarkable. is that it's easy to say you're going to work on equity, but you've done it in your practice, done it individually as
Well,
well.
thank you, Rose. I mean, the devil in the details there is, what does that level at which that community engagement interface takes place? And also how do we recognize need for improvement without kind of bad mouthing each other or saying
Yeah.
shame on you for not involving the community?
Mhm.
I mentioned that at the Pair Exchange Summit last year that, all these people in the room, and they're smart and we are committed and motivated to move the needle. And so that's the part that gives me, lots of hope. But if we want to be more efficient about it, if we want to, not have to see if something's broken and then go back to a version 2.0 or 3.0, if we want to improve things a little faster, it is important to involve the community. If there's a couple stakeholders or a couple speakers at a large scale COA panel, great. Then we also, like, Tennessee Oncology operates within One Oncology. I just left our monthly health equity committee group there to come and speak to you all. And we take the ideas that we're workshopping within our communities to that layer above. So sometimes it's not necessarily for COA or for every industry group to be individually accountable for that community engagement, but to have some type of communication channels or pipelines and to support those frontline practices for investing and being able to do that, and then share those best practices, or at least be listening to the ideas generated from those best practices. So it can look different from different people, but ultimately you do need them as a stakeholder in the room.
Thank you again, Dr. Martin. And I also want to thank all of you, our participants. We really appreciate you joining us on these calls. And at COA CPAN, we're all about keeping you engaged and educated. And I personally learned a lot today, and I hope all of you did too. Thank you again, Dr. Martin. And we have one last slide. A slide that everybody can hopefully be happy about. It's summertime. We're going to take an advocacy break in August, and I hope all of you have a fantastic summer. Thank you again, and thank you again, Dr. Martin. And as always, Dr. Martin's slides will be available. You should see them as early as Friday up on our website and on COA's UT page. So thank you again, everyone. Enjoy the rest of your day.